Hi everyone, and welcome to today's talk on bridging the gap from surviving to thriving in critical care. Firstly, a topic that I'm very passionate about, and secondly, in this particular time, also very relevant, given the COVID-19 pandemic we are currently facing worldwide, and the increasing number of patients who require ICU care and organ support. Now, when talking about muscle loss in the ICU, I always like to refer back to Sir William Osler, who already back in 1892 first commented on the rapid loss of flesh that occurs with severe sepsis. In his days, however, sepsis led to a fairly rapid death, and the primary focus was survival. Today, on the other hand, owing to our advanced organ support and ICU care, many patients survive this initial stage of sepsis, hence staying in ICU for longer, inevitably leading to an even greater loss in muscle mass. In fact, in 2012, Puthicchiari et al. Demonstrated an almost 18% drop in ultrasound-derived rectus femoris muscle cross-sectional area as a marker of muscle mass just over the very first 10 days in ICU, and was significantly amplified by ICU length of stay and severity of illness. In other words, those who stayed in ICU for longer, as well as those who were more severely ill, with severity of illness defined by the number of organs failing, suffered the greatest loss in muscle mass. A perfect example, this San Francisco-based nurse and recent COVID-19 survivor who, after waking up from a medically induced coma, found himself to be weak, frail, and 23 kgs lighter than when he went to the hospital 6 weeks earlier. I still had a trachea, I couldn't talk, and my hands were so weak that my phone felt like it was 100 pounds, he says. Now, in rehabilitation, he struggles to make it up a flight of stairs without getting winded. Now, just imagine he didn't have all this muscle prior to getting sick. What would he have looked like? And would he even have survived? Research tells us that almost 2/3 of our patients already enter ICU in a muscle mass deficit. And this was once again confirmed in a recent study by Loyard et al. Published last year, who, by assessing skeletal muscle area and density from abdominal CT scans at the level of the third vertebra, found that 60% of patients enter ICU with a lower than normal skeletal muscle area, indicative of a muscle mass deficit, and that interestingly, 45% of them also present with a lower than normal skeletal muscle density, which in turn indicates poor muscle quality and is thought to greatly contribute to the state of anabolic resistance we see in critical illness, and which we will get to a little bit later. Altogether, putting our patients at an even higher risk for the development of so-called ICU-acquired muscle weakness, where patients remain in ICU for a prolonged period of time, suffer ongoing immunosuppression, and hence recurring nosocomial infections, septic insults, pressure ulcers, impaired wound healing, and ultimately poor long-term functional recovery, if any. In fact, in this study by Loyard, as seen on this Kaplan-Meier survival curve, patients who presented with a low skeletal muscle area and density, in other words, poor muscle mass and quality, had a significantly lower long-term survival compared to their counterparts. Also, back in 2011, Herrich et al. Assessed survivors of ARDS 1 year after discharge from the ICU and found that despite the fact that 71% of them regained the weight loss during their ICU stay, all reported poor function and attributed this to the loss of muscle bulk, proximal weakness, and fatigue. The time is therefore long overdue for us as the multidisciplinary team caring for critically ill patients to bridge this gap from surviving to thriving, so that ultimately we can discharge ICU survivors with good long-term functionality and quality of life. The question, however, is, how do we achieve this? And before we even try answering this question, let's first revise the basic pathophysiology behind muscle wasting in critical illness, which in very simple terms can be described as the direct result of a shift from anabolism to catabolism. And I know this is a very busy slide, but what I would like to highlight here is, firstly, looking at anabolism, in other words, muscle protein synthesis, which is on the left-hand side of this slide. The master regulator behind anabolism is the so-called mammalian target of rapamycin, right there in the middle on the left, which, upon activation by amino acids as the primary anabolic stimulus, along with growth factors such as insulin and IGF-1 and muscle contraction through exercise, seen right there at the top of the slide, will stimulate the pathways for muscle protein synthesis. In the early acute phase of critical illness, however, given the great influx of pro-inflammatory cytokines combined with factors such as insulin resistance, bed rest, a reduction in the number of satellite cells in the muscle periphery, which are known to facilitate muscle recovery after injury, altogether puts our critically ill patient in a state of anabolic resistance, which means these normal anabolic stimuli are no longer able to stimulate this mTOR pathway for muscle protein synthesis, causing a shift from anabolism to catabolism, which is on the right-hand side of this slide, with the two main proteolytic pathways in skeletal muscle being, firstly, ubiquination right there at the bottom, also known as the ubiquitin proteasome pathway, which represents the main proteolytic pathway in skeletal muscle, and which is responsible for the release of free amino acids for hepatic gluconeogenesis, as well as for the synthesis of acute phase proteins and enzymes. And secondly, autophagy, which functions as a cellular housekeeping system responsible for clearing damaged organelles and toxic protein aggregates in order to preserve cellular integrity. And although inherently both of these pathways play an important role in promoting survival in the early acute phase of critical illness, the severity of the inflammatory response so early on will result in an over-exaggerated stimulation of both of these pathways and hence profound muscle atrophy. So coming back to the title of today's talk, Bridging the Gap from Surviving to Thriving in Critical Care, we need to find effective ways of helping our patients shift from a catabolic to an anabolic state as soon as possible during their ICU stay. And since we've now seen that amino acids are the body's primary anabolic stimulus, which means mTOR stimulation for muscle protein synthesis cannot take place in the absence of amino acids, the first stepping stone towards achieving anabolism would be meeting and then maintaining our patient's protein targets, which was beautifully shown in a study by Rihal et al. Published in 2017, where giving additional parenteral amino acids over and above standard nutrition therapy, increasing overall protein intake from 1.1 to 2.1 grams per kg per day, led to a significant improvement in whole body protein balance over the first week in ICU, confirming that an adequate amino acid supply early on in ICU may in fact help our patients achieve anabolism, and which in turn may then translate into improved long-term survival and functionality. As was observed in a recent study by Weish et al., who, by assessing protein intake among ICU survivors, found that for every 1 grams per kg per day increase in protein delivery during their ICU stay, there was a 17% reduction in the 3 months post-ICU mortality, reiterating that for every 1 grams per kg per day increase in protein delivery during their ICU stay, there was a 17% reduction in the 3 months post-ICU mortality, reiterating that increasing protein delivery during ICU stay may well assist with critical illness recovery and longer-term outcomes, if, of course, we can master the skill of meeting protein targets without overfeeding. As an earlier observational study, also by Weish et al., back in 2014, showed that energy overfeeding may cancel the potential benefit of an early high protein intake. And this was later also confirmed in a randomized trial, namely the EAT-ICU trial by Allingstrup et al., where the authors compared early targeted or goal-directed nutrition in the intervention group with standard of care during the first week in ICU, and found that despite a seemingly adequate energy and protein intake of 24 kilocalories per kg and 1.5 grams of protein per kg in the intervention group versus a much lower energy and protein intake in the standard of care group, no significant difference was found in physical quality of life at 6 months nor in any of the other secondary outcome measures. However, taking a closer look at the energy intake of the intervention group, these patients were most likely energy overfed, as this study, unfortunately, did not account for the additional calories from dextrose-containing IV fluids, such as 5% dextrose water, rehydration solution, 5% Maintenalite, often given as maintenance fluid, and which may have significantly contributed towards total energy intake. In fact, in this particular study, a significantly greater number of patients in the intervention group experienced hyperglycemia and required a significantly higher insulin dose versus the standard of care group, which confirms that the intervention group was most likely energy overfed, and which in turn may have cancelled the potential benefit of an adequate protein intake. This therefore raises the next important question, namely, how much protein and how much energy should we aim for and when? And on this note, I would like to quote Arabi et al. In their brand new review on protein intake and outcome in critically ill patients, saying, the optimal amount of protein intake in critically ill patients remains largely unclear and is considered a high priority for research. Ongoing clinical trials are likely to provide additional evidence for several important questions, including the dose, timing, type of protein, and the interaction with caloric intake and exercise. But until then, we need to be guided by the best currently available evidence, and luckily, a number of studies have been published over the past 2 to 3 years, which brings us at least a little closer to a definite answer. In the first study, Zussman et al. Retrospectively reviewed energy and protein intake in relation to resting energy expenditure as obtained by indirect calorimetry, which was on average 25 kilocalories per kg in this study, and a reference protein target of 1.3 grams per kg per day, and found, firstly, a significant nonlinear association between energy intake and 60-day mortality, with the resulting U-shaped curve revealing an increase in mortality when patients' energy intake exceeded 100% of their measured energy expenditure, which was providing more than 25 kilocalories per kg in this study, as well as when they were severely underfed, receiving less than 40% of their resting energy expenditure, calculated as less than 10 kilocalories per kg in this study. Interestingly, the greatest mortality benefit was seen with a 30% energy deficit, which means meeting 70% of energy expenditure, which was on average 18 kilocalories per kg, which is almost halfway between 15 and 20 kilocalories per kg. Secondly, as seen on this graph, protein intake showed a significant linear association with 60-day mortality, with a 1% improvement in survival for every 1 gram increase in protein intake. However, a protein intake of less than 1 grams per kg showed no overall mortality benefit. And therefore, to summarize, this study suggests, firstly, a protein intake of at least 1 grams per kg, but ideally 1.3 grams per kg or more, along with a 30% energy deficit, which most likely falls between 15 and 20 kilocalories per kg. Now, why an energy deficit per se? What is the real scientific rationale behind not overfeeding our critically ill patient, and especially early on in ICU? Well, do remember that in the early acute phase of critical illness, these two main catabolic processes, namely ubiquination and autophagy, will both lead to an endogenous calorie production that cannot be inhibited by an exogenous nutrient supply, and which may in fact cover up to 50 to 75% of our patient's energy expenditure initially. Furthermore, an over-exaggerated stimulation of autophagy may cause extensive mitochondrial degradation, leading to mitochondrial dysfunction, which in turn may render our traditional fuel sources such as glucose and free fatty acids as bioenergetically inert. In other words, the mitochondria are unable to utilize them as an energy source. They are unable to contribute towards ATP production. And therefore, it makes sense that targeting an exogenous energy intake equal to our patient's energy expenditure early on may directly translate into energy overfeeding, therefore serving as the scientific rationale behind maintaining an energy deficit during the acute phase of critical illness. In fact, exactly this was observed in a post hoc analysis by Peterson et al., where a higher calorie exposure during the first week in ICU was associated with a significantly higher hazard of mortality, whereas after week 1, a higher calorie exposure reduced the hazards of death, indicating that energy intake should be ramped up during the chronic or recovery phase of critical illness, as endogenous calorie production becomes attenuated and probably negligible. When it comes to protein delivery, however, recent studies indicate that protein intake should be ramped up quicker than that of energy, already in the first week in ICU. Firstly, this study by Cook et al., published in Clinical Nutrition in 2018, retrospectively reviewed protein intake in relation to 6-month mortality and found, first and foremost, the lowest long-term survival among those with an overall low protein intake of less than 0.8 grams per kg per day during the first week in ICU, highlighting the fact that restricting protein intake for the entire first week in ICU may worsen patient outcome. Secondly, dividing study participants into the following 3 groups based on protein intake: less than 0.8 grams per kg versus 0.8 to 1.2 grams per kg versus more than 1.2 grams per kg. 6 months mortality was the lowest. In other words, long-term survival was the highest, when protein intake was slowly advanced from a low protein intake over the first 1 to 2 days to an intermediate intake over the next 2 to 3 days, and ultimately reaching an adequate protein intake of 1.2 grams per kg by day 4, suggesting that protein intake should be gradually ramped up over the first 2 to 3 days in order to meet target by day 4. New research, however, suggests that there might be a subgroup of patients admitted to ICU who may even benefit from an earlier high protein intake, even before day 4 in ICU. And this was the study by Loyard et al., which I already alluded to right at the beginning of my presentation. While they compared an early high protein intake, defined as an average protein intake of 1.2 grams per kg or more between day 2 to day 4 in ICU, in other words, earlier than day 4, between 3 groups of patients. Firstly, those admitted with a normal skeletal muscle area. Secondly, those admitted with a lower than normal skeletal muscle area. And thirdly, those with a lower than normal skeletal muscle area and density, to see if any of these subgroups would benefit from a high protein intake earlier than day 4, as suggested by the Cook study. And as you can see on this graph, their findings were, firstly, no mortality benefit among those with a normal skeletal muscle area. Secondly, a definite mortality benefit among those with a low skeletal muscle area, with the greatest mortality benefit among those with a lower than normal skeletal muscle area and density. And this can also be seen on the Kaplan-Meier survival curve, you can see here, showing a significantly greater survival benefit when patients with a low skeletal muscle area and density received a protein intake greater than 1.2 grams per kg per day between day 2 to day 4, indicating that those with a low skeletal muscle area and density may benefit from an even earlier high protein intake. And the possible reason for this, as suggested by the authors, is that whereas a low skeletal muscle area is indicative of low muscle mass and therefore low protein reserves, low skeletal muscle density is associated with qualitative changes in muscle such as fatty infiltration and myosteatosis, which may create an environment with low-grade inflammation and insulin resistance, which contributes to anabolic resistance, and hence a higher protein intake may be needed in these patients in order to overcome anabolic resistance. And they strongly urge future studies to explore the use of high protein, low calorie formulations or additional protein supplementation in order to avoid overfeeding early on in this subgroup of patients as a means to overcome their anabolic resistance. In the interim, however, while we wait for more research to be done, as well as for an easy-to-use bedside tool to be able to accurately assess muscle mass and quality, let's be guided by the latest clinical practice guidelines from ESPEN and ASPEN, which first and foremost recommends early enteral nutrition, but taking it slowly, gradually increasing towards target over those first 2 to 3 days, so that by day 4, a protein intake of 1.3 grams per kg as per the latest ESPEN guidelines, or at least 1.2 grams per kg as recommended by ASPEN, are reached, whilst maintaining an energy deficit between 20 to 25 kilocalories per kg for the first week in ICU. And I definitely lean more towards 20 kilocalories per kg for the first week, as this is what ESPEN recommends one should do in the absence of indirect calorimetry in order to avoid potential overfeeding. And it is exactly here where our biggest dilemma lies, within this late acute phase of critical illness. In other words, between day 4 to day 7, where we need to reach protein targets, but without energy overfeeding, which is often difficult and not always possible, owing to the non-protein energy to nitrogen ratio of available formulations, as well as the additional calories from IV fluids. If we choose not to overfeed, which is of course the right choice given the first do no harm rule, would inevitably result in a protein shortfall. So how do we overcome this dilemma? How do we provide optimal gap cover to make up for this protein shortfall, but without overfeeding on non-protein energy? The first step is choosing a high protein, low calorie formulation, regardless of whether we are feeding our patient enterally or parenterally. And luckily, over recent years, our industry has really gone the extra mile to bring such formulations with a lower non-protein energy to nitrogen ratio to our South African doorstep. Then secondly, if still unable to meet our patient's protein target, we should add an additional protein supplement, which may be enteral or parenteral, of course, depending on your patient and the available feeding route. And lastly, once we've got step 1 and 2 in place, in other words, our patient's enteral or parenteral feed is running at the prescribed rate and they're receiving their additional protein supplement, if deemed necessary, we need to monitor daily whether our patient is in fact receiving the prescribed volume of his or her baseline enteral or parenteral formulation, as well as the prescribed protein supplement, so that if not, additional measures can be taken in order to still meet the prescribed energy and protein targets, such as compensatory feeding or supplemental parenteral nutrition in the event of feeding interruptions and or feeding intolerances. For example, in this recent randomized trial by Fetterplace et al., they managed to meet protein targets without energy overfeeding by using volume-based enteral nutrition and protein supplementation, whilst accounting for non-nutritional energy sources from IV fluids and medications, achieving a total energy intake of only 21 kilocalories per kg, along with a total protein intake of 1.2 grams per kg in the intervention group, and was associated with a significant attenuation in ultrasound-derived quadriceps muscle layer thickness as a marker of muscle mass, versus the control group that received an almost similar energy intake but a much lower protein intake, which is once again a confirmation that during the first week in ICU, giving adequate protein along with an energy deficit may indeed improve later patient outcome. Okay, so let's get practical for a moment and have a look at a few case scenarios where additional gap cover would be needed. In other words, additional protein supplementation in order to meet protein targets but without energy overfeeding, and how we then should go about. So, a patient, reference weight 70 kgs, gets admitted to ICU. We initiate early enteral nutrition on day 1, gradually increase feeds over the next 2 to 3 days so that by day 4 we can reach these targets based on the ESPEN-ASPEN clinical practice guidelines. So, step 1 would be setting our patient's energy and protein targets. And for case scenario 1, let's choose the latest ESPEN guidelines, which is 20 kilocalories per kg, as we do not have access to indirect calorimetry, and 1.3 grams of protein per kg. Step 2 would then be choosing a suitable product, and in order to provide 20 kilocalories per kg and 1.3 grams of protein per kg, we would need a formulation with a non-protein energy to nitrogen ratio of 70:1. And here I made a list of the currently available enteral and parenteral formulations in South Africa with a non-protein energy to nitrogen ratio of less than 100:1. So here's basically 3 options we can choose from with an appropriate non-protein energy to nitrogen ratio. If, however, these particular feeds are not available in our institution, or it doesn't meet another prerequisite, for example, we need a low electrolyte feed, we would need gap cover. In other words, we need to add an additional protein supplement over and above the baseline enteral parenteral formulation our patient is already receiving in order to up the protein, but without adding calories. Now, let's have a look at case scenario 2. This is a patient with increased protein requirements, for example, due to having an open abdomen or receiving continuous renal replacement therapy. And now we decide that we would like to target 25 kilocalories per kg and a protein intake of 2 grams per kg per day in order to compensate for the increased losses via the open abdomen or dialysate. For step 2, choosing a suitable product in order to provide 25 kilocalories per kg and 2 grams of protein per kg, we would need a formulation with a non-protein energy to nitrogen ratio of 53:1. Looking at our list of products again, we only have 2 enteral products with an appropriate non-protein energy to nitrogen ratio to choose from now. Once again, if these 2 feeds are not available in our institution or it doesn't meet any of the other prerequisites, for example, we might now need a low osmolarity feed or a fiber-containing feed, then we would need gap cover again. Now, case scenario 3 is a patient, reference weight 70 kgs, similar to case number 1, where we are targeting 20 kilocalories per kg and 1.3 grams of protein per kg. However, this particular patient is receiving a propofol infusion at 15 mL per hour, which already provides an additional 5 kilocalories per kg based on the weight of this patient, the reference weight of 70 kgs. Because do remember that propofol provides 1.1 kilocalories per ml, which means that in order to avoid overfeeding in this patient, our feeding prescription should only provide 15 kilocalories per kg, so that when we add the 5 kilocalories per kg provided by the propofol, we would in total give only 20 kilocalories per kg. For step 2, choosing a suitable product, in order to provide 15 kilocalories per kg and 1.3 grams of protein per kg from the feed, we would need a formulation with a non-protein energy to nitrogen ratio of 47:1. Looking at our list of products again, we again only have 2 products with an appropriate non-protein energy to nitrogen ratio. So if these 2 formulations are not available in our institution or it doesn't meet any of the other prerequisites, we would need gap cover. And then our last case scenario. Also similar to case number 1, targeting 20 kilocalories per kg and 1.3 grams of protein per kg. And once again, a patient with a reference weight of 70 kgs. This particular patient is also receiving a propofol infusion at 15 ml per hour, as well as a 5% dextrose solution at 80 ml per hour, which let's say is part of our unit's protocol for treating hypernatremia, each of which provides an additional 5 kilocalories per kg, which means that in order to avoid overfeeding, our feeding prescription should only provide 10 kilocalories per kg, so that when we add the 5 kilocalories per kg from the propofol and the 5 kilocalories per kg from the dextrose water, in total, we're still only giving 20 kilocalories per kg. For step 2, choosing a suitable product, in order to provide only 10 kilocalories per kg and still meet a protein target of 1.3 grams of protein per kg, we would need a formulation with a non-protein energy to nitrogen ratio of 23:1. Looking at our list of products again, we now have no enteral or parenteral product with a suitable non-protein energy to nitrogen ratio. And our only option here, in order to meet protein targets, would be gap cover, adding that additional protein supplement. So once we've identified the need for gap cover, as with the 4 case scenarios we just had a look at, we need to go ahead choosing an appropriate protein supplement. And here it's important to consider a number of factors which would ultimately determine the anabolic potential of the supplement we are giving our patient. Firstly, how much protein per additional volume does the supplement provide? For example, if it is an enteral formulation, which may be in powder or liquid form, how many doses or sachets do we need to provide per day in order to hit target? Very importantly, how much additional fluid would be needed for reconstitution purposes, as well as for flushing of the feeding lines before and after administering the supplement. If it is a parenteral supplement, we also need to consider the amount of protein needed and how much additional fluid that would add to the patient. Secondly, the type of protein, as certain forms of protein may elicit a greater anabolic response. For example, choosing a whey-based protein source versus casein may help attenuate inflammation, increase antioxidation, as well as muscle protein synthesis. Reason being that whey is a richer source of branched-chain amino acids, especially leucine, which in turn is a potent activator of the mTOR pathway for muscle protein synthesis. And based on healthy studies, 3 to 4 grams of leucine is needed per meal or bolus in order to maximally stimulate muscle protein synthesis. Furthermore, hydroxymethylbutyrate, also known as HMB, a known leucine metabolite, has gained much interest recently as a viable alternative to promoting protein anabolism, with the recommended dose being 3 grams per day. At the moment, there remains a limited number of studies on leucine or HMB supplementation in critical illness, and it is important to remember that ultimately, optimal dietary protein should contain a complete profile of amino acids, and that delivery of a single amino acid in large quantities may actually negatively impact muscle protein synthesis. Thirdly, the mode of delivery, as administering protein as intermittent boluses may result in a more physiological endocrine profile with a greater anabolic effect, given the cyclic surge in amino acids and insulin, as opposed to a continuous protein or amino acid supply, with healthy studies suggesting that a meal or bolus should ideally provide 0.4 grams of protein per kg, or 25 to 30 grams of protein, of which 10 to 15 grams should be essential amino acids and at least 3 grams of leucine per meal or bolus, and that the anabolic response may potentially be further enhanced when giving it in close proximity to exercise. Which brings us to the importance of mobilization as a concomitant therapy. According to Morton et al., combining an adequate protein intake with mobilization may help overcome anabolic resistance, especially when given in close proximity to each other, and therefore giving a protein bolus immediately before, during, or after a mobilization session in the ICU may give us the greatest anabolic response, and hopefully future research will provide additional evidence in this regard. So now that we've considered all these factors and we chose a suitable protein supplement, the next step would be monitoring. First of all, monitoring whether our patient is receiving his or her baseline enteral or parenteral formulation at the prescribed rate, so that if not, additional measures can be taken, such as compensatory feeding or supplemental parenteral nutrition. And secondly, monitoring if our patient is receiving and tolerating the protein supplement. For example, if perhaps your patient is receiving an enteral protein supplement but not tolerating it, one could consider changing over to an intravenous protein supplement. And lastly, now that we've looked at the late acute phase of critical illness, in other words, between day 4 to day 7, what about after day 7, when endogenous calorie production becomes attenuated and probably negligible, causing a rise in exogenous energy needs and making it somewhat easier to meet protein targets without energy overfeeding? Would our patients then still benefit from additional protein supplementation? Most definitely yes. Because do remember, as patients enter the chronic or recovery phase of critical illness, rehabilitation becomes key. However, the road to recovery is often bumpy, with patients often suffering from ongoing immunosuppression, nosocomial infections, pressure sores, etc. In fact, Rosenthal et al. Just published this study assessing the chronic critically ill population and found that despite early adequate evidence-based ICU nutrition, which basically refers to the first week in ICU, septic surgical ICU patients who develop chronic critical illness, in other words, staying in ICU for longer, exhibit persistent inflammation, immunosuppression, and catabolism with unacceptable long-term morbidity and mortality. Novel adjuncts are needed to reduce low-grade inflammation, promote anabolism, and improve long-term outcomes. Currently, no nutrition support evidence for this specific patient subgroup is available. However, a recent Nutrition Protein Summit recommends 2 grams of protein per kg per day for these critically ill and persistently inflamed patients, in other words, the chronic critically ill population, in order to achieve anabolism, which is often difficult to achieve, especially when these patients are weaned off enteral and parenteral nutrition and solely rely on oral intake to meet such a high protein intake. In these patients, Rosenthal therefore suggests adding supplemental protein, ideally throughout the day as 4 boluses, aiming for 0.4 grams of protein per kg per meal, which correlates with 2 grams per kg per day. And it may even be helpful to increase the dose up to 0.55 grams of protein per kg per bolus or meal, which correlates with 2.2 grams per kg per day, whilst giving preference to branched-chain amino acids, especially leucine, as an anabolic agent, with further potential benefit from other agents such as vitamin D, omega-3 fatty acids, and other pharmacological anabolic agents. In conclusion, what is the way forward? In order to bridge the gap from surviving to thriving in critical care, optimal protein delivery is paramount in order to achieve anabolism and thereby improve long-term recovery and functionality. However, more research is needed to ascertain optimal dosing, timing, type of protein, mode of delivery, and the interaction of protein with caloric intake and exercise. In the interim, based on currently available evidence, clinical practice guidelines, and expert opinion, a protein intake of 1.2 to 1.3 grams per kg per day or more should be reached after day 3, in other words, from day 4 onwards, whilst avoiding energy overfeeding, which may necessitate the use of low non-protein energy to nitrogen nutritional formulations, along with the use of additional protein supplementation in order to meet protein targets without energy overfeeding. Furthermore, the source or type of protein, mode of delivery, and concomitant therapies such as mobilization should be considered in order to further promote anabolism. And lastly, in the chronic critically ill population, staying in ICU for a prolonged period of time, a protein intake of 2 grams per kg or more should be targeted, preferably in the form of boluses, in order to compensate for the persistent inflammatory and hence catabolic state in these patients, in an effort to promote anabolism and facilitate the rehabilitative process towards better long-term outcome and functionality. Thank you for listening.